Okay, very good case. All right. Let's go to the last presentation now by Bhavanadhar Penta, another structural fellow who just arrived in time. And then we'll tally, and we are just to the last of the last now. We have uploaded his slide. Good.
Good evening, everybody. First of all, I want to thank all my faculty of our Sinai and also the faculty of NYTVS for giving me the opportunity. Today, I want to discuss about a patient of transcatheter tricuspid valve replacement for a torrential TR after failed TR, that is with a triclip. So this is an interesting patient. So he is a 73-year-old male patient, had many multiple procedures in multiple valves. He presented to us with progressive fatigue and dyspnea. He has a history of CAD, cabbage ×4 with severe MR, underwent an annuloplasty ring, repair with an annuloplasty ring, and MACE procedure for AFib in 2017. Has chronic ischemic cardiomyopathy with an EF of 45%, and also he had severe aortic stenosis, for which we did TAVR with a 29 millimeter SAPIEN valve in January 2024. He also has torrential TR. Initially, we evaluated him for the EVOQUE, but he failed screening. There are two things for his failed screening. One, his annulus size was huge, and at that time we did not have a 56 mm EVOQUE valve approved, and he underwent. So we took him for the TR procedure with two triclips, XTW2. One was placed across the AS commissure in Feb. Two were used in February 2024. One was placed at AS commissure and the other was placed at AP. But he had an SLDA with second clip attached only to the anterior leaflet with residual torrential TR. Later this, he was also he had a complete heart block, receiving a RV leadless pacemaker, that is MICRA. So there was a lot of issues going on, so heart team evaluation was done. He was deemed anatomically suitable for surgery, but considered secondary to his high complexity and also post-surgical status and a prior failed TR and a MICRA pacemaker in situ was considered high risk for the surgical repair. So we have planned him for TTVR with a 52 mm EVOQUE this time. He got through the screening process. We did under TE and ICE guidance and also under flow. So this is still images showing he had a torrential TR in the two-chamber view. And TE in the transgastric view, we can see the anterior clip. This is the AS commissure clip, which is still intact, and I would show in the images. Yeah, in this image, this is the AS commissure clip, which is intact, and this is the SLDA clip, which is only attached to the anterior leaflet. And these are the interprocedural images. We can clearly see here, this is the AS commissure clip, and this is the anterior clip, which is attached to the anterior clip, which is torrential TR. And in the RV outflow inflow view, we can see the we had good images. Lucky that with so much devices inside the heart, still we could get good TE images. And this is the SLDA clip, which is attached only to the anterior leaflet. So there were many difficulties in this management of this case. One comes to the wire placement, having the MICRA device in situ, and also we were also worried about capturing the leaflets through the anchors of the EVOQUE. So these are the intraprocedural MPR. Here, this is the one initial baseline. The same, we can see the both the clips, one with the AS commissure clip and the one with the AP commissure clip. Later, this is with the evoke valve, we went inside with 90 degrees opening of the anchors. Later, it was ventricularized anchors. Here we can see that there is a little anterior dive, and in this there is a anterior dive, and here it's a septal dive. So I'll come to this in the fluoroscopy also. Here we can see that the anchors are more hooked towards the septal leaflet, and here it is dived towards the anterior leaflet. But still we could get the both the clips into the anchor and the leaflets, and the clips could be both captured and jailed, and then later the valve could be deployed. And these are the fluoroscopy images. Here, this is where I was talking about the wire placement. Being the micra there in the RV apex made it a little complicated, but we made sure that the wire was appropriate in position and does not dislodge the micra which is there. And this is the capsule gap. And this is very important because the capsule gap shows that where the anchors are going to be released. Here, one important thing fluoroscopically, even though if we don't have a good TE images, having so much hardware in the heart, like having the tower which shows that the anteriorly placed clip, and having the clip also shows that we need to go below the clip. The release of anchors needs to be below the clip. Here it was not below the clip. If we see here, then after we realized that the release of the anchors are not going below the clip, we had to get the total system deeper into the RV. Later the release of the clip were made so that the all the leaflets could be captured. These are the different stages of release. This is at immediate release and just a release of those anchors. Here the 90 degrees release of anchors. We could see here in the fluoroscopy itself that the leaflets could be captured as the movement of the clips has come down. And here it's the ventricularization, and this is the unfast view where we could see that both the clips, this horizontal clip is the SLDA clip, which is between the AP commissure, and this is the actual clip which was there, the initial clip which is in the AS commissure between the aortic valve and the tricuspid valve. And this is the micra. And these are the post images. Post images, this is a still images. Both the ICE images and TE were showing that the position of the valve and the clips were good, and there was a trivial TR, residual TR, which I could show in this. Here, the place where there was the SLDA clip between the AP valve, there was a trivial TR which was acceptable. And these are the fluoroscopy of the images after it has been released. Both the clips were captured properly into the anchors, and this is the microvalve which we can see through the on-fast view. So the conclusions would be, and the take-home message would be, evoke valve can be done in patients with failed TR devices, or even with patients who are having ICD or pacemaker leads. It can be safely done, and it is feasible. And using of multimodality imaging, using TE, ICE, and even fluoroscopy, as we can see in this case, even without having support from TE, if the images are bad, fluoroscopy can also be used having that hardware. But we should know where the anatomic landmarks are there. And we should identify the anatomic landmarks in the fluoroscopy. And interprocedural imaging and procedural steps have to be standardized during TTVR procedure with prior TR device or CIED. And we would like to suggest that TR bridge to TTVR can also be considered in patients screened, who have been screened and failed for a evoke in the first place due to the larger annular area.
Very good. Questions? So basically is that after even failed the tricuspid TR clips, we can do the evoke. We have done what, two cases?
Yes.
Have you have you done it without the clip having SLDA?
No.
No. And which brings up the last point there. Tell me more about that. I haven't heard about that. And do you really think that's a viable option?
Yeah, I would, the last point what I would reiterate is the size of the annulus is one of the important thing, which is the reason why evoke patients, the patients are big, screening for the evoke is coming up. If we do a clip, probably that helped in our case also. The AS commissure clip which was holding was providing us an anchor so that the diameter of the annulus came down and the perimeter also has come down. We assume that that has helped us so that we could place the evoke in this patient. Probably we can try the clip first, and even though with the clip there's a progression of tricuspid regurgitation after the clip over the time, probably we can offer them the TTVR as an option. But we have to.
One thing I want to add, Dr. Mack, regarding your question about clip, so it depends where the clip is, right? If it's more centrally placed, it's more challenging. If it's commissural, close to AS commissure, it's easier. So you can have, like this case, SLDA and a clip that's there, more stable, but you can have commissural clips that are there without an SLDA and patient still has leak, you can do it. But if you have a centrally placed clip, then it makes a procedure almost impossible to do.
Right. Totally agree. But, and I think that's a word of caution for this bridge concept here.
Yes.
And you are involved in another tricuspid valve therapy, right? So what is promising? Because that's, one of our Kunal Sarkar was quite involved, and he was our interventional fellow many years ago at Sinai.
Saibal was?
No, Kunal Sarkar.
Oh, okay.
Kunal.
Yeah, I think one of them that's promising is a device called TriFlow, which is kind of like the Croy valve. It's a spacer concept, but it's inflatable, deflatable. Remember the original Fortis that Edwards had that didn't work because it was bankered? I think having this spacer that inflates and deflates with systole, diastole may have advantages, especially in patients in which the coaptation gap is significantly great and you don't want to put a valve in for whatever reason.